So here we go. So first off, do you have any questions, my friend? Anything we talked about as far as the setup of prostate cancer?
No, I think that the first question that I think physicians are probably wondering is one that your team has helped craft here, and I think that for physicians listening, is this what benefit is there for having 3 genes analyzed in the ExoDX prostate test compared to a single gene?
Right. A great question. The reason I was bringing all that earlier information up is I don't want this test or any test to be a sole deciding factor. I mean, even a biopsy that's positive doesn't tell you the full story, and neither does the ExoDX no test. But being part of an amalgam assessment approach is what I'm just trying to bring across. So, but it's a very powerful piece by itself. As far as what the the ExoDX we're looking at basically 3 types of messenger RNAs. It's a genetic approach to see. Let me back up and tell exactly where we use specialty tests. The PSA is an enzyme that comes from the prostate itself. So anything that insults the prostate, agitates the prostate, makes the PSA go up. Molecular tests do not care what agitation your prostate has had. So if you had sex in Las Vegas on a motorcycle, for instance, your PSA will be a disaster, but the molecular test should not be affected. So that is why it's such a powerful test that's independent of it. So therefore, what it's looking for is, and this is a functional genomic test, not a diagnostic genomic test. So let me explain that. A diagnostic genomic test is telling us, like the 23andMe tests, do I have the gene for blonde hair, blue eyes, and prostate cancer I'm going to give my kids? That's not what this is. This is a functional genomic test, which essentially means that is there genetic material being secreted or manufactured now, right now? So if a cancer exists, and it will be putting out genetic material, in this case, messenger RNA, these genes. And these are the 3 we'll mention. Specifically, the 3 that this test codes for is the ERG, the PCA3, and the SPDEF. But this is why it's powerful, because it's just looking for a cancer that's secreting this molecular activity all by itself, independent of the PSA. That's more of a physical agitation marker. So the original test, I won't mention the names just for the heck of it. The first one, though, was the PCA3. That test all by itself. Then one of these other marker tests through the years added the ERG test. So now, as these molecular tests evolved, there was 2 of them. The ExoDX is the first molecular test that now has three separate gene markers now that come together. Now, to answer your question, why are the 3 important? Well, because every time you add another gene that you can track, you are adding more specificity to what you're doing. You're, in this case, able to literally triangulate with the 3 a higher reliability of, in this case, chance of an aggressive cancer. So, and I might be off on the exact percentage, but the PCA3 test back 15 years ago was about 72% reliable. When they added the ERG test and you had 2 genes available, it popped it to about 78%, 79%, depending on who you were talking to, of reliability. Now that we added the SPDEF and you added a 3rd to be able to triangulate it, it's up to 91, 92%. I know the Exo people, they might say it's 92. I thought it was 91, but 91, 92% reliability out of the gate doing it one time is a game changer, in my opinion.
So, and for physicians listening, what kind of reporting and interpretation is pretty important for the physician? So, you know, this is a physician ordered test. That's the first question. And then,
yes.
What type of reporting, more importantly, does the physician receive back from the ExoDX test? And our guest today is Dr. Phranq Tamburri. We'll put the links to XxoDX.com in the links below. But first question, you know, physician ordered test, yes or no? And then how easy is it to get? And then second question is, what type of reporting am I getting and how do I interpret it? And if I need just like we with whole genome sequencing tests we saw a few years ago, there were some genetic counselors and coaches that would help the physician interpret the results. Is that necessary? So unpack those two questions for us, please.
Okay. Well, the way it's, first off, as far as getting a consultation with it, no, you're not going to get consultation with it. That's kind of where I would advise the first part of my discussion is that type of information, is how to incorporate it as an aggregate assessment approach, and falling back to those original questions. What is the goal for them? Is it getting rid of a cancer if it's in them, or is it not dying from it? How scared are they? Are they able to live with the prostate cancer? The longevity versus quality of life. Those are the questions that are the consultation, in a way, of how to incorporate these findings into really how you manage the case. So I just advise, get to know your patient, spend time talking with them, and the other patient you have in your office, usually their wife. Okay, because I don't have one patient, I have two of them in there, and they're usually equal, if not more, making the decisions. So keep that in mind. I'm not trying to be flippant with your question about counseling on it, but that is, to me, the job of the doctor if you're going to take on this type. Or simply, if this test is positive, that might just be all you need, is to send off to the urologist or a doctor who will ask those questions later on. Now, going back to your other question, how's it reported? Well, you get back, basically it's a one sheet, which keeps it nice and simple. You get a score from 0 to 100. And the cutoff is 15.5. And it's a very basic little linear line, little graph there. And 15.5 and under is considered a negative. Over 15.5 is a positive. So a negative, and I have more insight on this, but on the technical side, the negative just means that there is a low chance that they have an aggressive prostate cancer. Okay, so I want to be very clear about this test. It does not tell you whether you have prostate cancer or not. It doesn't. Technically, you could have a score of 1 and you can have prostate cancer all over that prostate. It's kind of shocking to say. People kind of question, well, what is the point of the test? Remember I talked about those first questions. The point of the test is not whether or not you have cancer, it's whether you have the type of cancer that can kill you. So if the number is low, under 15.6, it either suggests that there's no prostate cancer there of any meaning, or there is prostate cancer, but it's an indolent old man cancer form that won't get you. So that's why I try to get clear with a patient before they spend the money on the test or through insurance is, if your expectation of the test is to tell you don't have cancer, this test is not for you. If it's coming down to whether you're going to die from it or the chance that you will, then this test is fantastic. And for most men, once they get past the concept of having cancer and they progress to that more kind of a more mature way of looking at, like a medically way of maturing through the problem that they have, then this test, they see the value in it. So you get a score of 15.5 or 15.6 and under, means a decreased likelihood of high-grade prostate cancer, which essentially means a Gleason 6. That's the lowest grade that you can have. If it's 15.6 or higher, then there's an above average risk that it can come back a high Gleason score, which the system tags as a Gleason 7, 8, 9, or 10. Remember, it only goes from Gleason 6 to 10. We almost all agree Gleason 6 is low aggression, 7, 8, 9, 10 is high aggression. So that's the quick answer to that. I will add, though, that a Gleason 7 is debatable whether that is aggressive or not. So I'm going to add in my 2 cents here, which is for you doctors listening. This is not the official way to utilize it, but for me, using this test as much as I do, I look at this, that a 15.6 and lower, I would consider the green zone. 15.6 to about, I don't have an exact number, to about 40, I consider the yellow zone, where most likely, yes, it might be legally aggressive, but it's probably going to be a low 7 maybe a high 7 is what I have personally found. When the number is 40 and higher, that's when you start to get into the red zone that I find, where the risk is even higher, where you start to see the 8s, the 9s. I mean, I haven't seen a 10 in years, but yeah.
Let's talk about what makes the ExoDX prostate test unique and move on and unpack to those. Our guest today is Dr. Tamburri. We're coming in for a landing here on our interview with Dr. Phranq Tamburri. He is with exosomedx.com. We'll put the links to his practice as well as to the exosome test. First question before we jump into this, what would be my next step as a physician to order this test? What's required? And then, I mean, do I just go to a website? Who do I talk to if I want more information? And then we'll talk about what makes the test unique. But let's give them a little bit of context for what their next steps might be so they have an idea.
So yes, you would contact XxoDX. I'm gonna make sure I have that correct. And then you set up an account with them. They will send you these test kits. They are large styrofoam boxes, and they also send with you a little collection kit. The beauty, though, is, as I said, you can actually just have it sent to their house if you have a patient out of state, or just have them take it with them. The way it's collected is they collect it at home in the bathroom. There are 3 main rules. The first rule is they must collect, most important, by the way, it's like don't feed gremlins after midnight, right? It's one of these three rules. Number 1, you must collect the initial squirt of urine, okay? The initial squirt. The advantage to this test over the other tests is that you do not need a DRE. I know I've been redundant on that point, but it's a very game-changing point here. They just pee in the morning. So number 1, collect the initial squirt of urine into this collection tube. Number 2, we recommend that you collect it in the morning, first void in the morning. And number 3 is I recommend that they have this test performed at least a week away from DRE, and especially Dr. Tamburri, you know, because we kind of violate them with ultrasounds and everything else. But in all seriousness, you know, a few days at least from sex, no orgasm, no motorcycle riding, just try to get a clear number if possible. It's questionable whether it would really affect it or not, but those are the 3.
Okay. I will let you go ahead and wrap up here with the last few slides, and then we just have 1 or 2 more questions for you.
Okay.
So if you'd like to choose which slides you're looking at, that's fine.
Yeah. Well, this slide you're on is kind of good just to rehash these quickly, the advantages of the test. I mean, you don't need a PSA, or the reliability of the PSA is not as important when you're using a molecular test. The ExoDX, I also point out, is the most accepted that I'm aware of amongst urologists. I know flavors change here and there, but for the more the active surveillance community, the Prostate Cancer Research Institute, when I attend their conferences and I speak to physicians there, the ExoDX tends to be the one now that most urologists are moving to. I'm not trying to always be part of the cool club, I can assure you, but it is more, I don't want you to think this is just a naturopathic tool. This is the one that most urologists I know doing this type of work are utilizing, which also means the reason I use this test as well is, as a naturopath, I want conventional doctors to be able to utilize the tests that I do. See, if I use a bunch of alternative tests, whether if I have belief in them or not, the average urologist has no credibility to the system. But if I use their tools and play with them in my sandbox, it works well for integrative medicine. So that's why the ExoDX is a great tool for licenses that we can do. It also says here, you do not need a medical doctor or a nurse to do anything else with the patient. All you need to do is send them the test kit. They do it at home. You don't need a DRE. So in the COVID world, you can send it to them. It's much easier. It's non-invasive. So although this is not legally binding like a biopsy about cancer, although a biopsy diagnosis doesn't always tell you the full story either, this is probably the closest we can get for a lab test to give us the chance a legitimate cancer is there without going further with a biopsy. We can, like it says here, it's utilized for men age 50 or older. I have used it in men younger who will understand it's designed for 50 or older if they're high risk. Also for PSAs between 2 and 10, this is an excellent option to utilize. Ultimately, I think if you're going to assess or do any risk at all for prostate cancer based off of a PSA, consider some form of functional testing or imaging at least.
All right. Well, our last two questions. The first one's going to be obvious because you got it right in front of you here on the next slide. And that is, what makes a liquid biomarker useful? For those listening in the car, our guest today is Dr. Tamburri, and he is with ExoDX.com. We'll put the links in his bio and his practice and contact information for the team over there so you can learn more about this test. But what makes a liquid biomarker useful? Second to last question for you today.
Well, that's kind of a loaded question right there, because it's right there. But yeah, basically, why is a liquid biomarker like the ExoDX useful? And it's all of the above. I mean, it aids clinical decision making clearly, and I maybe went over the top on that in the first part of this lecture, but it truly does. It improves the PSA specificity for early detection of prostate cancer, especially this newest variant, the ExoDX. It can reduce the incidence of metastatic disease by basically ruling out the more aggressive forms versus the indolent forms. Remember, you can live with an indolent form in most cases. It's the metastatic disease that's the problem. As I tell my students and my patients, prostate cancer can't kill you if it stays in the prostate. It can only kill you if it gets out. So that's normally the question. By the way, yes, it can kill you if it blocks the prostatic urethra, to be really technical, but that's not what patients are concerned about. And then lastly, it can assess a man's risk for high-grade prostate cancer, which at the end of the day is really what this tool is designed for.
Great. Well, our guest today has been Dr. Phranq Tamburri, and the team at Exosome has a test here that I think all physicians should be leaning into, learning more about, contacting Exosome to learn more about it. And our final question, we'll put the links to ExoSomeDX.com. That's ExoSomeDX.com. But again, we'll put all the links, the bios, some of the questions that we've talked about. If it's okay, we'll put a version of this slide deck in the show notes as well. But from your experience of working with this test, working with physicians, working with patients, if you were to think about and I asked this of all of our guests, and that is, at the end of the day, you're just you have a moment of like reflection in the car by yourself, and you're like, that's why we do this. Like, that's why that was amazing. Like this is why I do this. This is why I do this test. That's why I administer this. This is why I studied this. What's one story, I'm sure of many, because usually that's the answer. Which one do I choose? What's one story that comes to mind recently related to the ExoDX test that you're thinking like that it did exactly what it's supposed to do, and all of the pieces fell into place, and maybe somebody was better for it or family was? So I'll let you share and we'll conclude with that.
Well, yeah, you're right. The answer is many, but I'll give you an amalgam of cases, but one I had very similar. And that is cases that I often see, because I often get referred the more challenging cases. I don't usually see easy cases, and I'm honored, but it is a challenge. And I see often PSA independent cancers. And these tend to be usually the most aggressive cancers. They tend to be either familial, they tend to be Agent Orange. It's the reason I asked about this, carcinogens. And what these are cancers that you can have a Gleason 8, 9, or 10. And the PSA is under 2. I mean, I had a case where the entire prostate, all 12 out of 12 cores were Gleason 10. The man had Agent Orange back in N.M.D. His PSA never went over 1.5. So you have a case sometimes that on paper The PSA is normal, the percent free is normal, the PSA density is normal, everything's normal, and yet imaging or something about the case, you can smell a rat. You just know there's a cancer there, but you can't sometimes get something concrete enough to either show another doctor or the patient themselves, especially when that patient is reluctant to go to a urologist or to take the next step. Well, that's where this type of test, the ExoDX or molecular tests like this, are the missing link. They act as the referee. So when that test comes back, and that's happened with a patient the other day, it came back a super positive, came out like 75 or whatever it was. That is completely contrary to a PSA of 1.5. Something's not right at the circle K, as they say. And therefore, I was able to convince the patient to go further, and I saved his life about that.
Well, this has been, I think, incredibly educational for physicians listening. And Dr. Tamburri and the team over there at XxoDX.com, go to ExoSOME, D as in dog, X as in X-ray, .com. We'll put the links to the show notes as well. Dr. Tamburri, thank you for being our guest today. And then we'll want to thank the team at Exosome. Physicians, if you're listening, please contact them for more information. Look into this. I think that Dr. Tamburri has shared some very valuable education for physicians that you can lean into, that I think would really help your patients with prostate cancer detection, and give you another tool in your tool belt to help your patients. And as we say around here a lot, it is no longer about being the best doctor in the world anymore. It's about being the best doctor for the world, for your patients, and for your local community. And the team at Exosome and Dr. Tamburri are doing some unique things, and we want to you to lean into that position. So thank you for being our guest today, Dr. Tamburri.
Thank you. Great job. I appreciate the interview.
Thank you.